Good morning. Welcome, everyone. Welcome you to the Health for the World International Grand Rounds. Our Grand Round speaker today is Dr. Yara Abtau. Dr. Abtau has finished her fellowship at Roswell Park Comprehensive Cancer Center and is going to start as a faculty at University of North Carolina. She has a focus on breast cancer and immunotherapy. So we'll be giving a talk on metastatic breast cancer. She is also a JCO and ASCO editorial fellow. We really thank Dr. Abdow for giving this Health for the World medical grand rounds. Dr. Abdow, you can start when you're ready. Thank you so much.
Sure. Thank you, Ravna. Thank you for having me, and thank you for joining me today in these crazy times out there in this pandemic. So I appreciate you all joining me today. So I'll be talking to you about metastatic breast cancer. This is a hefty topic, so please feel free to ask any questions throughout my talk. All right, let's see. I have no conflicts of interest to disclose. So just an overview, I wanted to show you the staging system for breast cancer. Stage 0 means you have precancer or carcinoma in situ. When you get to stage 1 in breast cancer, we're mostly talking about a breast cancer in the breast that has not gone anywhere else. Stage 2 tends to be either a breast tumor that's large in size, which is at least 2 centimeters in size, or a breast tumor that has spread to local lymph nodes in the axillary lesion. Stage 3, we're mostly talking about lymph node positive disease, which means you have a breast tumor that has spread to the lymph nodes around it, whether it's in the axilla or in the breast area, but it's a local spread of the disease. Stage 4, which is going to be the main focus of our topic today, is basically once the tumor has left the breast, gone into those local lymph nodes, and started going into the blood to different sites or organs in our body, that's when we call it stage 4 or metastatic breast cancer. And that is where the focus of our topic is going to be today. So stage 4 breast cancer, as we said, so the picture on the left shows you a tumor in the breast. And then in the middle, we see the multiple lymph nodes that the breast cancer can travel to. And once they go through these lymph nodes and spread throughout the body, they can go to different organs. Breast cancer in particular likes specific organs in the body. It can either go to the brain, and that's mostly common in triple negative breast cancer and HER2 positive breast cancer. It can spread to the lungs, the livers, or the bone. The bone metastasis is usually more common in hormone positive breast cancer. It's another spot that usually gets some breast cancer is the adrenal glands. It's rare, but it can happen. So if we look at survival over the years of metastatic breast cancer, we realize that survival has been improving. And as we see here, the curve with the gray line over here, patients since 2010 so far has been doing much better than patients who lived through the 1990s, indicating that research, drugs, a lot of things are getting better in this arena of medicine. So what are our challenges with metastatic breast cancer? We have a lot of multiple efficacious agents in metastatic breast cancer, but despite that, patients eventually have progressive disease. And then it remains uncertain what's the best treatment choice once a patient progresses. We can't decide what's the best treatment for the patient unless we actually go through it and try it and see how the cancer responds to it. And most importantly, metastatic disease continues to be an uncurable disease in breast cancer, unfortunately. And we definitely need more translational clinical research and trials in metastatic breast cancer. So what is the goals of treatment in metastatic disease? So our goals is basically to prolong survival as much as possible. We want to control the symptoms of the patient. Metastatic disease can be symptomatic. It can be painful. So our goal is to make the symptoms as manageable as possible. And at the same time, while we're trying to control these symptoms and prolong survival, we want to minimize toxicity as much as possible from the therapy. So overall, we want to improve the patient's quality of life. Since we can't cure them, we might as well give them a good quality of life with our treatment. And that is, in summary, our goal of treating metastatic breast cancer. So metastatic breast cancer is a very heterogeneous disease, and one size does not fit all. So you have to be very careful with your choice of drugs. You have to take into account a lot of factors. If we look at patient factors, you need to look at patient's performance status, what are their comorbidities, what are the genetic differences, and what prior treatment have they received. If you're looking at the disease itself, we have to look at the fact of disease-free interval, which means if a patient had early stage breast cancer, they got it resected, how long were they disease-free before they developed metastatic disease? And that really tells you a little bit about their prognosis. Other disease factors involve the sites of metastasis and how much volume of disease there is. Very important factors in treating metastatic breast cancer is determining the estrogen, progesterone status, and the HER2 status of the tumor. Really, our treatments differ drastically depending on the receptor statuses of the tumor. So breast cancer, I think most of you know that it's made up of different subtypes. We have our hormone positive breast cancer, estrogen positive and progesterone positive. In our first circle, that's the majority of breast cancer, makes up to 65 to 75%. Then we have our HER2 positive breast cancer that makes up about 15 to 20% of breast cancer. And also the last but not least, the triple negative breast cancer subtype, which makes up to 15% of breast cancer as well. Now, the HER2 breast cancer subtype can overlap with hormone positive, which means you can be hormone positive and HER2 positive at the same time. And that's why we see the circles overlapping here. So I want you to remember this. We always get a biopsy when it's a new metastatic lesion. So if someone had breast cancer, let's say a year ago or 2 years ago or 10 years ago, and then develops a spot in the liver or the bones or anywhere, you can't really prove that this is metastatic breast cancer unless you get a biopsy. You'd be surprised to see how many patients have different types of cancer or maybe a benign tumor in there. So you always want to get a biopsy to prove that you had a metastatic lesion. And the other important thing in breast cancer is that the subtype is very, very, very important. And subtypes can differ from your primary tumor. So if you had a HER2 positive early stage tumor that got removed years ago, and you develop a new breast lesion years later, that doesn't mean that you have to have HER2 positive breast cancer again because your earlier lesion was a HER2 positive breast cancer. So you want to biopsy that new spot to make sure the subtypes are what you expected so that you can treat them accordingly. So this is just, I wanted to put this diagram in because I wanted to show you basically every breast tumor is checked for these receptors. PR stands for progesterone, ER is estrogen, and HER2 is, we'll talk about it a little later. HER2 is another important receptor. These three receptors can be targeted with treatments. And that is why it's very important to see if they are actually pronounced on our breast tumor or not. Again, back to the molecular subtypes. So a new way of dividing breast cancer these days is dividing them into luminal A, luminal B, HER2 positive and triple negative breast cancer. They've divided luminal A and luminal B, as we see here. Luminal A is almost always positive hormone receptors and almost always negative for HER2. These tend to be slow-growing tumors with good prognosis, as you see here in the Ki-67, which means how fast cells are dividing. And luminal A tends to have a slow-growing tumor with a low Ki-67, indicating that they're growing slowly. Luminal B also tends to be hormone positive, but it can also be HER2 positive. So they tend to be a little more aggressive, a little more faster growing than luminal A. HER2 positive is known to be aggressive. These subtype tends to be hormone negative, so they are a little more aggressive than luminal B. And the triple negative breast cancer is known to be very aggressive. It has no receptors to target, and it divides pretty fast and spreads pretty fast. Again, it's very important to know the tumor subtypes in breast cancer because really your prognosis depends on that. As you see here, again, luminal A has the best prognosis, triple negative has the worst prognosis. Again here, wanted to emphasize the subtype and its role in determining survival. This is metastatic stage 4 breast cancer. As you see, triple negative breast cancer has about 17% overall survival in comparison to the hormone positive HER2 negative subgroup, which has about 47% survival. So the black curve here that's doing poorly is the triple negative curve. And then the blue curve here is the hormone positive curve, and the red curve as well, they have hormone positive disease. So going into treatment of metastatic breast cancer. So this is always a multidisciplinary care in metastatic breast cancer. You gotta involve a lot of parties in the treatment of the patient. Medical treatment is a very important part, which we're going to be discussing extensively in this session. Radiation surgical treatment, less important, but definitely part of the care, especially if there is a lesion that's symptomatic that you need to take care of locally. Another very, very important part of care in a metastatic breast cancer patient is palliative and supportive care. We always want to make sure the patient is comfortable, they have a good quality of life, so it's always beneficial to involve palliative and supportive care, even in early stages of their disease. Again, another important part is their nutrition. A pharmacist needs to be on board and make sure their therapies are right, physical therapy if available, and social work help if available. So things to consider when you're starting your treatment for breast cancer patients. You got to consider the patient's goals and preferences. You got to make sure this patient that you're treating wants the treatment and actually wants to go through this, and this is, and you're both on the same page. You got to make sure the patient is in good condition to receive your treatment, which means the patient's performance status is good. They can are out and about, they do their own shopping, they do their own daily activities, not someone bedridden and unable to move. You don't want to give aggressive treatment to that kind of patient. So overall, you want the benefits to outweigh the risks. At the end of the day, we want to do no harm. So again, emphasizing on the palliative care and supportive measures. It's okay to talk about palliative care. A lot of patients get scared a little bit when you start talking about palliative care. They think they're about to die, but that is untrue. We involve palliative care to make sure the patient's his symptoms and needs are taken care of. And at the end of the day, it's about providing the best quality of life. And in order to do that, we need to involve supportive measures in addition to active treatment. So in regards to palliative care, I want to emphasize that this is our guidelines, the National Comprehensive Cancer Network guidelines, and the palliative care and supportive care is part of our guidelines. So whether it's above here in the hormone positive, HER2 negative disease, or in the HER2 positive disease at the bottom of this slide. At the end here, as I've marked in red, if you have no benefit after 3 sequential lines of chemotherapy, or your performance status is very poor, for example, if your patient is bedridden and can't really benefit from additional treatment, you need to say, hey, let's talk about keeping you comfortable. Let's talk about how can we provide you with the best quality of life, and discuss supportive measures with the patient. And that should be always an option on the table for the patient to choose from. Now, what about surgery in metastatic breast cancer? Do we remove the primary tumor when your cancer has already spread? That is a question that has been asked over and over again. And only recently, actually 2 weeks ago, we had our big oncology conference. And we discussed this trial that has been going on for a while. Basically, patients presented with de novo stage 4 breast cancer, which means they started off with metastatic breast cancer at presentation. They started being given medical treatment. And if they had no progression for 4 to 8 months on the medical treatment, they were randomized to either continuing just medical treatment or systemic therapy alone, or doing systemic therapy in addition to surgically removing their primary tumor. And what did we find? We found that there was no survival benefit from doing surgery on the primary tumor. On the last two graphs in on the right, the HER2 positive disease and the hormone positive disease, we see how the curves are overlapping, meaning that there was no survival benefit for removing the tumor over just giving systemic therapy. In the triple negative on the far left graph, we actually see that the patients did a little worse when you actually did the surgery. As we see here from the yellow curve, these are the patients that received surgery in addition to systemic therapy. They did a little worse than just receiving systemic therapy. So what did we conclude? We concluded that local and regional therapy of the tumor when they have stage 4 does not improve survival in patients with metastatic disease. So once it has spread, there is no role for removing the local breast tumor. They also tested for improvement in quality of life for patients who had their primary tumor removed, and there was no improvement in quality of life when you actually did surgery. So at this time, we say that surgery has no role in metastatic breast cancer unless you require it for symptomatic or palliative measures, which means you have a primary breast tumor that's getting really infected, it's getting infections all over again, it's hurting the patient, it's affecting their daily lives. That is when you might consider surgical measures to that tumor to improve the patient's quality of life. Back to our main goal. So going into systemic therapy. Systemic therapy is very, very broad in breast cancer. And we divide systemic therapy again based on the subtype of breast cancer that we see. So if you have endocrine positive or estrogen positive or progesterone positive breast cancer, the mainstay of treatment is endocrine therapy. In HER2 positive breast cancer, the mainstay of treatment is HER2 targeted therapy or anti-HER2 therapy, where we want to target that HER2 receptor. In the triple negative population, there are no receptors to target, so unfortunately, chemotherapy is the mainstay, although we do have some exciting new therapies that I will be talking to you about in a little bit. In the endocrine therapy portion of things, in the hormone positive patients, we start off with endocrine therapy, but down the line, once they stop responding to endocrine therapy, we revert to chemotherapy at some points. So this is a list of all the FDA-approved treatments in the United States. And as you see, every year we're having more and more drugs approved for metastatic breast cancer. And we're only halfway through 2020, and we have 3 drugs already approved for metastatic breast cancer, as you see here below. It's pretty exciting times now in the cancer world as we see more and more therapies for these patients, and they're doing better and better with time. So let's start off with a hormone-positive breast cancer. I'm going to be interchangeably saying estrogen positive, progesterone positive, or hormone positive. That all means hormone positive breast cancer. So when someone asks you, what do you do in hormone-positive breast cancer? Is it chemotherapy or endocrine therapy? The answer is always endocrine therapy. It's always the standard first-line treatment in hormone-positive breast cancer. When do you use chemotherapy? Chemotherapy is only used if patients have severe or life-threatening symptoms and you need to reduce the tumor as soon as possible. Let's look at this algorithm for metastatic breast cancer. So if you have a hormone-positive breast cancer, you ask yourself that question: do you have 3 months to wait for a response? AKA, what does that mean? Means, do you have lesion, for example, a lung lesion that's sort of blocking the patient's airways that you need to shrink it as soon as possible? Or if you have tumor in the liver that's causing a lot of pain for the patient or compromise to their liver function, is that something you want to shrink as soon as possible? If that is a yes, then you might want to consider chemotherapy, because chemotherapy would shrink your tumor faster. But if you have 3 months to wait and the cancer that is spread in the body is not life-threatening or not causing any severe symptoms, then the answer is endocrine therapy. So you start with endocrine therapy and you sequentially treat them with different types of endocrine therapy until they stop responding to endocrine therapy. Usually our cutoff is 3 consecutive endocrine therapy regimens. If the patient is not responding to 3 consecutive endocrine therapy, then our recommendation is to go to chemotherapy at that point. So patients who progress on one hormone therapy can respond to another hormone therapy. And hormone therapy, I mean endocrine therapy. I'm also going to be using that interchangeably. So if you respond to a hormone therapy in the first line setting, means that's the first treatment we gave you for 30%. The second line response is probably a little less than the first line response, and also third line is a little less than second line. And that is why usually we tend, after third line of sequential endocrine therapy, we tend to revert to chemotherapy as the response to endocrine therapy becomes less and less, and patients become resistant to endocrine treatment. So when we say endocrine therapy or hormonal therapy, what are we talking about? Tamoxifen is a selective estrogen receptor modulator. A lot of you have heard of tamoxifen. It's a drug we usually use in the premenopausal setting. This drug blocks estrogen receptor, as we see in the diagram, and that is why it's used in premenopausal patients who have estrogen in their body. Basically use the tamoxifen to block that estrogen receptor in the breast cancer cell. The other endocrine therapy is aromatase inhibitors. Those are usually used in the postmenopausal setting. So aromatase inhibitors, they block an enzyme called aromatase, as we see at the top of the diagram. Aromatase is an enzyme that converts your adrenal hormones, your testosterone, into estrogen. And that is usually what happens in postmenopausal women, because the ovaries stop producing estrogen, so the body starts getting estrogen from different types of hormones, and aromatase helps us with converting those hormones to estrogen. And the aromatase inhibitors basically block that enzyme, and prevents more estrogen from being formed in postmenopausal women. These are all pill form therapies, so they're all pills. The different types of aromatase inhibitors that are available are anastrozole, letrozole, exemestane. I put the generic form of these drugs as well for you to see. In the postmenopausal setting, they've tested aromatase inhibitors with versus tamoxifen, and they realized that aromatase inhibitors are better drugs than tamoxifen in the postmenopausal setting. And all of these three drugs are pretty much the same. They have pretty much similar responses and pretty much a similar time to progression. Therefore, until proven otherwise, we consider all the all the aromatase inhibitors, whether it's anastrozole, letrozole, or exemestane, all these drugs are pretty much equivalent. We tend to interchangeably use them because of their side effect profile. Even though their side effect profile is pretty much the same, patients usually tend to have postmenopausal symptoms when they take these drugs, which makes sense because you're decreasing the estrogen in your body. But what's unclear is why some patients can tolerate one drug versus the other, because they sort of have similar side effect profile. Now, another endocrine therapy that I wanted to talk to you about is fulvestrant. Fulvestrant is a selective estrogen receptor downregulator. So it downregulates the estrogen receptor and decreases the estrogen in the body. These are injections, they are not pills, and they're intramuscular injections that are usually given monthly to the patient. So the trial called FALCON evaluated whether we can use fulvestrant in the first-line setting. So what did they compare it to? They compared it to anastrozole, which is an aromatase inhibitor in postmenopausal women. So they divided patients to receive either anastrozole or fulvestrant. And as you see in the graph here, the patients who received fulvestrant in the red curve did better than the patient who received anastrozole in the first-line setting. So if you have a metastatic breast cancer patient, you can either start them off with the endocrine therapy pills, which is aromatase inhibitors, or tamoxifen, versus you can argue that fulvestrant did better than anastrozole, and you can start off your patient directly with the injections. But when they divided these patients who received fulvestrant into patients with visceral disease and without visceral disease, they realized that patients who had visceral disease as in your organs are actively involved, lung, liver, or adrenal glands. Those are visceral organs. And if they are involved with cancer, using either or fulvestrant or anastrozole didn't really make a difference, as you see in the graph on the right, where the curves are overlapping. On the graph on the left, in patients who don't have visceral disease, which means usually in hormone-positive breast cancer patient, means that you only have metastasis in your bones, not in your visceral organs. And in those patients, giving the injections tends to do a little better than giving the pills. Now, moving on to the next type of treatment, which is CDK4/6 inhibitors. These are very exciting treatments in the hormone-positive breast cancer setting. So, cyclin-dependent kinase inhibitors are basically drugs that inhibit your CDK4 cyclin D1 complex. This complex activates a tumor suppressor gene, retinoblastoma, phosphorylates it, which tends to activate a transcription factor E2F, leading to proliferation of cells and growth of the tumor. Why is it important in hormone-positive breast cancer? Because cyclin D1 is usually overexpressed in breast cancer, in particular in patients who are hormone positive. So by targeting that and inhibiting this pathway, we tend to decrease tumor progression and tumor division of cells. So there are 3 drugs that are cyclin-dependent kinase inhibitors. Those are palbociclib, ribociclib, and abemaciclib. So this is a busy slide, but I wanted you to see the 3 types of CDK4/6 inhibitors that are approved in the United States and what type of trials were used to approve these drugs. Pretty much they have similar efficacies and similar, more or less similar side effect profile. We'll talk about the differences between these drugs in a few minutes. So CDK4/6 inhibitors in the first line setting means the patient comes in, first type of treatment you give them is CDK4/6 inhibitors. This is very important because CDK4/6 inhibitors, in addition, so I want you to emphasize this, the CDK4/6 inhibitors are not given alone. They're always given with other types of endocrine therapy, either aromatase inhibitors or fulvestrant injections or tamoxifen. Now, there's different occasions to using different combinations. In the first line setting, we are usually talking about a CDK4/6 inhibitor in addition to an aromatase inhibitor in postmenopausal women. So when they combined palbociclib, which is one of the CDK4/6 inhibitors, with letrozole, which is one of the aromatase inhibitors, we see a very significant improvement in progression-free survival when compared to patients who only received an aromatase inhibitor, as you see in the red line. This is the PALOMA trial that got palbociclib approved. The Mona Lisa trial looked at ribociclib, which is another CDK4/6 inhibitor, in combination with letrozole, an aromatase inhibitor. Again, we see how the combination drug in the blue line did better than letrozole alone in the red line. Monarch 3 trial looked at the third CDK4/6 inhibitor, abemaciclib. Abemaciclib was given with an aromatase inhibitor or an AI. Again, we see an improved survival in the patients who received combination treatment compared to the patients who received an AI by itself. So these trials are what got CDK4/6 inhibitors approved in the first line setting with aromatase inhibitors in the US. And that is the most common regimen that is used in the metastatic first line hormone positive breast cancer setting. Now you'd ask me, what about premenopausal women? In premenopausal women, Mona Lisa 7 have looked at these women in the setting of ribociclib, which is one of the CDK4/6 inhibitors, and in addition to tamoxifen or an aromatase inhibitor. However, for these women, they all received ovarian suppression, usually with goserelin injections. We suppressed their ovaries, we converted them into postmenopausal status, we gave them ribociclib with tamoxifen or with an aromatase inhibitor. And as you see here, again, the combination with ribociclib, even in premenopausal women, did better than the combination of, than the drug alone of tamoxifen or an AI. So the combination with CDK4/6 inhibitor, better progression-free survival. Now the second line, can CDK4/6 inhibitors be given in the second line? Which means a patient came in, had metastatic breast cancer, we were giving him we're giving her usually anastrozole, and they progressed on anastrozole by itself. So what are you going to do now? You can give them CDK4/6 inhibitors in the second line setting, but you can't combine those CDK4/6 inhibitors with aromatase inhibitors again. So you got to combine them with something else, and this is where the injections come into play, the fulvestrant. So the PALOMA 3 trial looked at palbociclib, again, one of the CDK4/6 inhibitors, with fulvestrant. And we see here an improvement in progression-free survival when the combination of fulvestrant was used with palbociclib compared to the patients who only got the injections of fulvestrant in the red line. Similarly, the Monarch trial looked at abemaciclib, the other type of CDK4/6 inhibitor, With fulvestrant, again, we see an improvement in the progression-free survival and also in overall survival. This is recent data showing that the combination of CDK4/6 inhibitors with fulvestrant do better than patients who receive fulvestrant on its own. Again, MONALEESA-3 looked at the third CDK4/6 inhibitor, ribociclib. Ribociclib did better with fulvestrant than giving fulvestrant alone in metastatic breast cancer patients. So what are the adverse events of these inhibitors? So these are targeted inhibitors. They are not chemotherapy. They don't tend to give you the typical chemotherapy side effects. We do see neutropenia though, and this neutropenia is not really associated with as much immunosuppression as we see in chemotherapy. We can also see some thrombocytopenia, diarrhea, mostly seen in abemaciclib, fatigue, and nausea. And you can see that the side effect profile is pretty much similar, with the exception of abemaciclib, which tends to have more GI symptoms and less neutropenia. So what are the major differences between these three drugs? Why do we have three different drugs for which do the same exact thing? Honestly, it's a pharmaceutical thing here in the US. Different pharmaceutical companies produce different inhibitors. They are pretty much the same when it comes to efficacy. Palbociclib, ribociclib is given daily. Abemaciclib tends to be given twice daily. So in patients who don't remember to take their drugs twice a day, you might want to consider once daily regimen. The schedule in palbociclib and ribociclib, you have a week off for your cells to recover. In abemaciclib, it tends to be a continuous regimen. You don't have a week off. When it comes to neutropenia, you see it in all three drugs, less seen in abemaciclib as we saw in the previous slide. Fatigue, nausea, diarrhea. Fatigue, is seen in all three drugs. Nausea, diarrhea is seen mostly in the abemaciclib. We said that this drug has the most GI symptoms. QTc prolongation is only seen in ribociclib. So when we give patients ribociclib, we tend to do EKGs in the beginning to make sure their QTc is not prolonged. With regards to CNS penetration, brain metastasis is less common in hormone-positive breast cancer, but if that is a situation that we see, abemaciclib tends to penetrate the blood-brain barrier more than the other drugs, so you might want to use abemaciclib in that setting rather than the other two CDK4/6 inhibitors. What are other therapies in second line and beyond that we use in hormone-positive breast cancer? Other therapies that I'm going to talk to you about briefly is everolimus plus exemestane. Exemestane is a aromatase inhibitor. Everolimus is an mTOR inhibitor. So the combination of these two drugs in the second line or beyond, so those are patients who either received endocrine therapy alone or endocrine therapy with CDK4/6 inhibitors. You can transition them, if they progress, you can transition them to everolimus and exemestane. This was compared to exemestane by itself, and the Bolero trial showed that the patients who received the combination regimen with everolimus did better than the patient who just received an aromatase inhibitor, which is exemestane. Another exciting drug that was approved last year for breast cancer patients who are hormone positive is alpelisib. Alpelisib is a targeted drug. It is used with combination of fulvestrant, the injections. So we use these combinations in patients with PIK3CA mutations. These mutations are found in 40% of patients with hormone-positive metastatic breast cancer. So if you have a patient who was on endocrine therapy and progressed, and you want to see what type of treatment you want to go to next, you can take that tumor and send it for mutational testing. And if they if they ended up having a PIK3CA mutations, which can occur in 40% of the patients, you can treat them with the combination of alpelisib plus fulvestrant. So this was an FDA-approved drug last year for patients who received prior treatment with either an aromatase inhibitor with or without a CDK4/6 inhibitor. And this is the SOLAR-1 trial showing you that a combination of alpelisib plus fulvestrant compared to fulvestrant by itself showed an improvement in progression-free survival for those patients who received the combination therapy. So to summarize, I threw a lot of information at you. It's very confusing. I agree. I'm going to try to go through an algorithm that maybe explains it a little better. So a management algorithm for hormone-positive breast cancer. You get a hormone-positive breast cancer patient. What do you give them in first line? You might want to decide you just want to give them tamoxifen if they're premenopausal. If they're postmenopausal, you might want to decide I just want to give them a aromatase inhibitor. These are pills. They're easy to take. And they don't have a lot of side effects. My preference, if the patient has a good performance status and can tolerate a little more pills, is combining a aromatase inhibitor with a CDK4/6 inhibitor. CDK4/6 inhibitors are also pills, so they would be just a combination of pills. And as we saw earlier, the combination did better than using a aromatase inhibitor by itself. So my preference would, and the preference here in the US for the first line setting, is to use the combination. But if you used an aromatase inhibitor or tamoxifen by itself, it's not a wrong choice. So this is first line. If you progress on either aromatase inhibitor or tamoxifen by itself, in the second line setting, you can use a CDK4/6 inhibitor. So if you don't want to use it in the first line setting, if patient progresses and doesn't do well on an aromatase inhibitor by itself, you can incorporate it in the second line setting, but at that stage, you have to use it with the fulvestrant injections rather than with aromatase inhibitor. Now, if you progress on a first line CDK4/6 inhibitor, then you probably want to switch to something else. You can't give them CDK4/6 inhibitors again if they progress on CDK4/6 inhibitors. So you might want to switch to the fulvestrant injections, or you might want to do tamoxifen. Other types of therapies in the third line setting, you can use exemestane, everolimus combinations, as we saw, or alpelisib fulvestrant combinations if they have the PIK3CA mutation, or if they don't respond to any of those drugs and they become hormone resistant, you can revert back to chemotherapy. So hopefully that made it a little clearer in what, how do you approach a patient with hormone positive, HER2 negative metastatic breast cancer. So before we go to HER2 positive breast cancer, if there's one thing I want you to remember from hormone positive breast cancer is that you always pick endocrine therapy. You keep going through the endocrine therapies available until the patient becomes resistant to endocrine therapy before you switch to chemotherapy in hormone positive breast cancer. If a patient has a very large symptomatic tumor and you want to shrink it real fast, you can start off with chemotherapy and then switch back to endocrine therapy. That is another appropriate regimen. But if there's no life-threatening or severe symptoms, you always use endocrine treatment in hormone-positive breast cancer. Now, switching to HER2 positive metastatic breast cancer. HER2 positive amplified breast cancer can make up to 20% of invasive breast cancers. These patients tend to have poor prognosis. HER2 positivity is associated with high-grade tumors and more aggressive disease. But patients are now living much longer because we have excellent treatment options for those type of patients. Anti-HER2 therapy is what I mean by excellent treatment options. Anti-HER2 therapy is a must in HER2 positive metastatic breast cancer patients. So what does HER2 stand for? It's human epidermal growth factor receptor 2. This is HER2 is one of the tyrosine kinase receptors, which tend to be 4 of them, as we see in the picture here. HER2, what it does is basically it combines with other types of HER2 from its family, and it activates a signaling pathway that leads to cell proliferation, cell division, survival, and invasion. So this is the pathway that leads to tumor growth in HER2-positive disease. And that is why we want to block that HER2, to block this pathway, to block the tumors from dividing in HER2-positive metastatic breast cancer. So how do we test usually our breast cancer tumors for HER2? We usually do immunohistochemistry, which is an easy and a fast method. As you see in the picture here, the picture on the top is a HER2 positive immunohistochemistry. We tend to score these tumors. If they score 0 or +1, that is negative, means they are not HER2 positive. If they score a 2+, means we don't really know. It's a little equivocal and confusing. So we tend to send those tumors for FISH testing. And if you score a 3+, then that's clearly, I apologize, back to this slide. That is clearly a hormone, a HER2 positive breast cancer. So 0 to 1 is negative, 2 is we don't really know, 3+ is HER2 positive disease. Now, when it's 2+ and we don't really know, we tend to do a test called FISH. The FISH is more a fancier test, let's say, for HER2 testing. And it tends to tell us if the tumor is HER2 positive by having a FISH ratio of greater than 2.2 or a HER2 gene copy greater than 6. So sometimes tests can come back to you and they don't say exactly what is if the tumor is HER2 positive, and you got to figure it out. So basically with IHC, you looked at the scoring system and you determine whether it's positive or not. And with FISH, you tend to look at a ratio or a gene copy, and you see if it's greater than a certain number, as we see here, 2.2 or 6, then it tends to be HER2 positive disease. So what are our HER2 targeted drugs? There are many, many HER2 targeted drugs, and there are more drugs being tested right now as we speak. These are some of the drugs that I have here included in the slide. Trastuzumab is the most popular, the first drug that is used to treat HER2 positive breast cancer. Trastuzumab blocks the domain 4 of HER2, so HER2 has 4 domains. As we see in the picture here, trastuzumab blocks domain 4. Another HER2 targeted drug is pertuzumab. Pertuzumab blocks domain 2 of the HER2 structure. We have trastuzumab emtansine, that is TDM1. This drug tends to be, it blocks domain 4 because it has trastuzumab, and it's combined to a cytotoxic molecule that goes into the cell and kills tumor cells. Trastuzumab deruxtecan is another monoclonal antibody drug conjugate. It's also trastuzumab combined to a cytotoxic drug that kills tumor cells. And then you have your tyrosine kinase inhibitors, lapatinib, neratinib, tucatinib. Those tend to bind to the tyrosine kinase domain, as we see in the picture below. And those are also HER2 targeted drugs. So all these are HER2 targeted drugs, and they target HER2 from different aspects or domains. Now, first line setting, patient comes in, metastatic breast cancer, they turn out to be HER2 positive. What do you start off with? The answer is always trastuzumab in combination with chemotherapy. Trastuzumab has to be there. It's an anti-HER2 drug. It's the backbone of HER2 therapy. And we always tend to use them with chemotherapy unless the patient cannot tolerate chemotherapy. If there's one drug you have to choose for metastatic breast cancer patient with HER2 positive disease, if you can only choose one drug, then I would say trastuzumab or HERCEPTIN is the drug of choice. So this is the first trial that looked at trastuzumab in combination with chemotherapy. And as you see here, this is the red line is the line that used trastuzumab in combination with chemotherapy. They did better than patients who actually got chemotherapy on its own. And on the bar graph here on the left, we see that patients who got the combination in the red bar here had a better response rate to the treatment than patients who got chemotherapy on its own. So the combination does better. Trastuzumab and cardiotoxicity, they ask that a lot, even in medicine boards. Trastuzumab can cause cardiotoxicity. It can reduce your ejection fraction in about 10% of patients, but only 1 to 4% of these patients actually develop symptomatic heart failure. The prevalence of cardiotoxic effects of trastuzumab increases significantly when you use it with anthracycline chemotherapy. In these days, we almost never combine trastuzumab with anthracycline. It's becoming less and less common. There are more and more trials telling us that we don't need to use anthracyclines in HER2-positive disease, and we're using less and less anthracycline, so we're seeing less and less cardiotoxicity because we're not combining these regimens together. When you want to use trastuzumab, you always have to have a baseline echo of your heart, and you have to keep repeating those echoes to monitor for cardiotoxicity. Now, if a patient drops his ejection fraction, that doesn't mean they're going to stay like that forever. It is a reversible process, and patients tend to get better once you stop the trastuzumab therapy. So it's a reversible side effect. Next is pertuzumab. So trastuzumab and pertuzumab are always combined together. Pertuzumab is not used on its own. They are combined, and why that is because they act on different domains in the HER2. Remember, we talked about trastuzumab acting on the subdomain 4 of the HER2 molecule, and pertuzumab binds to the domain 2 of the HER2 molecule. And they tend to have a synergistic effect of blocking HER2 by combining to different domains of the HER2 receptor. So the CLEOPATRA trial looked at trastuzumab in combination with pertuzumab and combination of chemotherapy. And that was compared to patients who only got trastuzumab and chemotherapy. So they randomized these patients with HER2-positive metastatic breast cancer to receiving only chemotherapy and trastuzumab, or combining trastuzumab with pertuzumab and chemotherapy. And we found that the combination regimen that included the pertuzumab had better overall survival. We see 15 months improvement of overall survival in the patients who received the pertuzumab in addition to the trastuzumab. So we're targeting HER2 from 2 different domains, and where that synergistic effect definitely translated into a better survival, longer survival in these patients. So what's the conclusion from all of that? The conclusion is that in a first-line HER2-positive metastatic breast cancer, if there are no contraindications, the first-line recommended therapy is to give a chemotherapy, usually a taxane. We avoid anthracyclines, so we usually use a taxane. Docetaxel is the most commonly used regimen. We combine that with trastuzumab or HERCEPTIN, and then combine it with pertuzumab. This is a regimen that we refer to as THP, T from taxane, H from HERCEPTIN, and P from pertuzumab. This is the HER2-positive first-line treatment in metastatic breast cancer for HER2-positive disease. So what we do is we start the combination regimen, but it's okay to stop the chemotherapy after 6 to 8 cycles. If your patient's doing well, you don't have to keep giving them the chemotherapy. You can drop the chemotherapy and just continue with the HERCEPTIN and the pertuzumab. You have to know that combining pertuzumab with trastuzumab does not give you an additional cardiotoxicity, okay? So you don't have to worry about that. What you do have to worry about is diarrhea. You get a lot more diarrhea with the combination regimen. So you got to ask your patient if they're having diarrhea and how can we control that diarrhea with some meds. So that is the common side effect we see with the combination regimen. Now, if you progress on this regimen, the patient's done well, for months or years and then progress. What do we do next? This is where trastuzumab and emtansine comes into place, TDM1. So TDM1 is basically trastuzumab in combination with emtansine. So trastuzumab binds with the domain 4 in the HER2 receptor. And then when it binds to it, it brings that cytotoxic molecule emtansine into that cancer cell. And this emtansine is an inhibitor of microtubule polymerization. So it inhibits those microtubules and prevents the cancer cells from dividing. So trastuzumab emtansine, or TDM1, is a combination of an anti-HER2 therapy and a cytotoxic therapy. Not really a chemotherapy, but sort of similar to a chemotherapy. And this is an IV infusion. It's given to patients every 3 weeks, once every 3 weeks. This was approved with the EMILIA study. Those were patients who have received prior treatment with taxane and trastuzumab and progressed. They were either given TDM1 or other regimen that was used in the past, capecitabine, lapatinib. And we see here the progression-free survival. The curve at the top where TDM1 was used in blue did better than the other combination therapy. So TDM1, also it showed improvement in overall survival. So progression-free survival and improvement in overall survival in patients who received TDM1 drug. So conclusion from this trial is that in the second line setting in HER2 positive metastatic breast cancer, once they progress on your combination of THP, you're going to use TDM1 drug. The common side effects you see with this drug is neuropathy. So patients might start complaining of some tingling and numbness in their fingers and their toes. You can give them breaks from therapy if that happens. And other common adverse events that we see is a drop in platelets or an elevation in your liver function tests, which may need dose adjustments. So you got to be careful doing those CBCs and LFTs when you're giving those drugs to patients. Now, to summarize all of that, another algorithm, this is patients with HER2 positive breast cancer. Let's walk through the red boxes here. So you have a patient with HER2 positive breast cancer. In the first line setting, you tend to give a trastuzumab in combination with a pertuzumab in combination with a taxane chemotherapy. Once they progress on that regimen, your second line setting would be TDM1. Once they progress on TDM1, you have several other options from the list we talked about. You can use tucatinib combination with capecitabine trastuzumab. You can use capecitabine with lapatinib. You can use lapatinib with trastuzumab. There are other regimens that you can use. The key, though, is you always have to use an anti-HER2 targeted therapy. If you go to the right, the blue boxes here, if a patient has HER2 positive breast cancer and hormone positive breast cancer, it is okay to combine HER2 therapy with endocrine therapy. So if you want to give an anti-HER2 treatment with chemotherapy, you can add your aromatase inhibitor to that drug regimen, okay? If we go to the far left, patients with HER2 positive disease can develop brain mets. The brain metastasis is most commonly seen in that subgroup of patients, actually. So for brain metastases, if they're active and symptomatic, we tend to treat them locally, either by surgery or by radiation. And that radiation can be to the whole brain, or it can be stereotactic if available in the institution, where you actually just radiate that tumor. Or you can use systemic therapy. And that is the exciting part of HER2 positive breast cancer treatment that I would like to talk to you about. So brain metastasis, as we said, can occur in up to 50% of HER2 positive metastatic breast cancer patients. So you always, if a patient has HER2 positive breast cancer, you're always going to keep an eye out on symptoms like visual changes, headaches. You always want to get that brain MRI, make sure the patient doesn't have brain metastasis. Now, why I'm excited about this is that we have a new drug called tucatinib, which is an oral tyrosine kinase inhibitor that was very recently approved this year for HER2 positive disease. And this drug has shown very, very good data on controlling disease in the brain. We don't have a lot of drugs that cross the blood-brain barrier and control disease in the brain. Usually brain disease or brain metastasis we control with surgery or radiation or local treatment. Having a drug that we can give systemically that controls both our disease in the body and disease in the brain is pretty significant. So this is from our 2020 ASCO annual meeting. This is the HER2CLIMB trial. This is a trial that looked at tucatinib in combination with that trastuzumab, in combination with capecitabine, which is a chemotherapy, compared to patients who did not receive tucatinib, only received capecitabine and trastuzumab. And as we see here, the progression-free survival for patients with brain metastases that received tucatinib in combination with trastuzumab and capecitabine, as we see in the blue line here, did much better than patients who did not receive tucatinib. Now, looking at only their brain progression, the patients who received tucatinib progressed much later than patients who did not receive tucatinib. So for the brain metastasis per se, this is a great drug that controls brain disease. Not only that, we saw an improvement in the overall survival in patients with active brain metastases. So that's huge. In patients with brain lesions, patients tend to deteriorate very rapidly, and their survival tends to decrease very rapidly. And as we see here, there was a significant improvement of over 9 months for patients who received the combination of tucatinib with the trastuzumab and the chemotherapy in comparison to the patients who did not receive tucatinib, which is the TKI. So that is very exciting data. Definitely a patient with brain metastases, you want to consider giving them a tucatinib combination regimen. Now moving to our triple negative breast cancer disease, or TNBC is what I'm going to be referring to it as. So these are the drugs for metastatic breast cancer. Most of these drugs, unfortunately, are chemotherapy, and chemotherapy remains to be the mainstay of treatment for triple negative breast cancer. Because it's triple negative, it has no receptors to target. However, pretty recently, we have immunotherapy, atezolizumab, approved in 2019, in March of 2019. So more than a year ago, we had this drug approved, and it's pretty exciting times for immunotherapy in the cancer world. And in breast cancer per se, only recently have we started incorporating immunotherapy in our metastatic breast cancer patients. So I'm going to start off with talking about immunotherapy. So what is the immunotherapy I'm talking about in this setting? It's called immune checkpoint inhibitors, okay? So immune checkpoints are a normal part of the immune system. Their role is to prevent an immune response from destroying healthy cells in the body, okay? So immune checkpoints are basically, when I say immune checkpoints, if you look at the diagram below, I'm looking at the PD-1 and the PD-L1. So the PD-1 is usually found on our T cells. T cells are part of our immune system. They fight cancer cells, and they fight any foreign bodies. They fight anything that harms the body. So T cells have these PD-1 checkpoints, and these PD-1s, when they bind and join with the PD-L1, they tend to turn off the T cell. So basically, if I join the PD-1 and the PD-L1, I'm telling the T cell, calm down, T cell, this is not a foreign body, this is not toxic to the body, don't kill it. So I'm turning it off, okay? So when proteins on the surface of the immune cells recognize and bind to the proteins on other cells, some are tumor cells. So what the tumor cells are very smart. What they do is they develop these PD-L1 receptors so that they combine with these PD-1s on the T cells and turn them off. That way our T cells in our body did not recognize these tumor cells. They think they're just healthy cells in our body, and they don't destroy them, okay? So this is a trick that the tumor cell uses. So like here, for example, the tumor cell, the T cell has the PD-1 joined to the PD-L1 on the tumor cell, and it's turned off, so it's not attacking the tumor. So immune checkpoint inhibitors, which basically are PD-1 or PD-L1 inhibitors, and that's going to be the focus of our talk here, they inhibit either PD-1, like we see in the PD-1 inhibitor in the picture here. They inhibit the PD-1 on the T cell, or they inhibit your PD-L1 on the tumor cell, okay? So if you inhibit those, you prevent that the PD-1 from joining to the PD-L1. That way the T cell is not turned off, and it tends to kill the tumor cell. Okay, so immunotherapy drugs tend to tell your body, they teach your body that, all right, your T cells need to be taught how to recognize the tumor cells and fight them and kill them. And how do we do that? By blocking that PD-1 or PD-L1 and not letting them join together and turn off that T cell. So there are many FDA-approved PD-1, PD-L1 inhibitors: pembrolizumab, nivolumab, atezolizumab, avelumab, durvalumab. These either inhibit the PD-1 on the T cell, or they inhibit the PD-L1 on the tumor cell directly, okay? And these drugs, they tend to work by the same mechanism of action. And they have been approved in different types of cancers, and they're mostly used in melanoma. A lot of melanoma are being treated by anti-PD-1, PD-L1 drugs. Only recently, breast cancer is part of that algorithm. And what we look at when we say breast cancer and immune checkpoint inhibitors, we're usually talking about atezolizumab here, Tecentriq, which is a PD-L1 inhibitor. I'll talk about it in a second. I just want to talk about the adverse event of immune checkpoint inhibitors. So this is not chemotherapy. This is basically immunotherapy. Means I'm modulating our immune system to recognize cancer cells. So when I modulate that immune system to recognize cancer cells, we can modulate them a little extra and they start attacking normal cells, right? Because we're blocking those PD-1 or PD-L1s. And sometimes the tumor cell gets, the T cell gets activated and starts attacking our normal organs. And depending on what type of organ the T cell starts attacking, that's the side effects we're going to see. Commonly, we see rashes because dermatitis, because what happens is the T cell starts attacking our skin. Or we see diarrhea, which is another common side effect because of colitis. The T cells love to attack the colon. And a lot of times we see just fatigue from the therapy itself. Rarer side effects that are seen from checkpoint inhibitors attacking other organs. The skin inflammation, the dermatitis we talked about. The T cells can start attacking our lungs, causing pneumonitis, so patients can present with cough and chest pain. Patients can present with belly pain and diarrhea because of colitis and inflammation in our belly. It can actually attack the pancreas, causing diabetes. We can have inflammation in the liver, leading to hepatitis. Hypophysitis is inflammation of the pituitary gland. Myocarditis, inflammation of the heart muscle. Nephritis, inflammation of the kidneys. Thyroiditis, inflammation of the thyroid gland. And we can have inflammation of the nervous system as well, leading to numbness, muscle weakness, etc. So you got the point. Is basically these T cells can attack any organ and can cause inflammation in any organ of our body. So we have to be pretty alert to those types of adverse events. They are rare, but if they happen, they are serious and they need to be managed accordingly. And they are mostly reversible and can be treated with basically suppressing our immune system again with steroids. So back to breast cancer and atezolizumab, that is our PD-L1 inhibitor that is used in combination with chemotherapy in advanced triple-negative breast cancer. This is the New England Journal of Medicine article that talks extensively about this drug. So basically, this combination regimen has showed improvement in progression-free survival and overall survival compared to chemotherapy alone. But we have to remember that the improvement in survival was only seen in the PD-L1 positive subgroup of patients. What does that mean? That means is we take that tumor from the patient, we send it for PD-L1 testing. Remember, we talked about the PD-L1 being a receptor on the tumor cells, and that is how they trick the T cells and they turn them off. So we got to find those PD-L1. If the tumor doesn't have PD-L1, then giving atezolizumab is not going to help. So we got to find a tumor that has PD-L1 positivity. So we determined the PD-L1 status by the Ventana PD-L1 assay. This is an immunohistochemistry picture on the right, showing you a PD-L1 negative tumor and a PD-L1 positive tumor. They can stain these PD-L1s on the tumor cells themselves or on the immune cells surrounding the tumor cells. In this setting, in the breast cancer setting, we tend to stain the immune cells around the tumor. Anything over 1% is considered positive. So if you have a 1% or above, then you are PD-L1 positive, then you qualify for a combination of this new exciting drug of immunotherapy in combination with chemotherapy in the first-line setting. And only about 40% of triple-negative breast cancers test positive. So you can test negative, and that if you test negative, then the choice is chemotherapy on its own. But if you test positive, then giving a combination with the PD-L1 inhibitor atezolizumab is definitely worth a shot. So the next is chemotherapy. Is there a standard first-line agent for chemotherapy? Not really. You can use anthracyclines or taxanes as first-line agents. There is not really evidence showing that a specific sequence of chemotherapies improves overall survival. The response rates are really influenced by the line of therapy rather than the specific agent. So if I give anthracycline first and I give a taxane second, and the patient responds to the anthracycline longer than the taxane, that doesn't mean that the anthracycline is a better drug. It just means that I've given the patient already one chemotherapy, and the fact that they progress on that chemotherapy and are needing another chemotherapy is what sort of decreased their response rates rather than the chemotherapy itself. The treatment decision of what chemotherapy should be used should be individualized to the patient. So you want to talk to the patient what kind of side effects they're going through, what kind of treatments they got in the past to see what is the best treatment for this patient. Do you use
Dr. Abdul, sorry to interrupt you. I think we are past the 1 hour, so we might have to finish up right now. Maybe this is a very interesting topic. Maybe we can have a part 2 if you don't mind of the talk.
Sure.
And I really appreciate you doing this for us. This is an excellent talk, very informative for our audience. Let me quickly ask, our classroom in Cameroon, if they have any questions. Shamla, do you mind unmuting them?
Okay, 1 second.
Okay. And thank you so much, Dr. Abdul. We really appreciate this. And I'm glad that we had our audience from Mingo Baptist Hospital also join us. They were able to join us today for this interesting topic. Okay, I don't see any hands raised or any questions yet. But if anybody has any questions, you can send it to us by email. Oh, you actually see a hand raised. Okay. Yeah, please go ahead. Sorry, we cannot hear you. Give me 1 second. Hey, Albert, can you hear us? All right, you can go ahead now.
Okay, I'm Dr. Pia Francine. So, thank you so much for your presentation. The first question that I wanted to ask is this for a setting like this, because I think that more and more we have guidelines for limited income countries. You know, all all these drugs, like the patient with HER positive. Here in this hospital, we treated only 2 patients with that, and it is so expensive. You see how the family struggle, and usually it's not even available. The 2 patients on treatment, we have to request from those drugs from India. The drugs came directly from India. The second thing that I also want to mention here, probably the way that the patients are presenting in Europe or in US is completely different from what we see here. You know, we have a really, really advanced disease. Usually you want to save a life at the time that the patient is presenting. Massive pleural effusion. The patient is coming with convulsion maybe because she has brain metastasis. So usually we do we just stabilize the patient, and those patients, because they have visceral massive disease, they will need chemotherapy. Another important thing that is sometimes difficult to follow this guideline is that our patient, if you when a patient is coming at the beginning of the treatment, the patient has a biopsy in this hospital, but you have to send the receptors somewhere else. Sometimes the receptor, we have to send the sample in Europe, or the sample has to go to US. And you will have to do something because those patients are coming with advanced disease. And I know that, for example, today with maybe the pediatric oncology, we have what we call pediatric oncology in developing countries. They have different guidelines because of what it is available, and also for the resources that are available. So I just want to ask, is it not something like this for breast cancer in limited income countries? Thank you.
That is an excellent question. I definitely understand that these therapies are not available worldwide. What I would say briefly to answer your question because of the time is you can't go wrong with chemotherapy. If something is acute and you want to shrink something, whether it's pleural effusion causing difficulty breathing or a big mass that you want to shrink, you're not going to go wrong with chemotherapy. You can start with chemotherapy while the tumor is being sent somewhere else to check for the receptor status. But I would emphasize no matter what, receptor status is very, very important. So you can't start chemotherapy while the receptor status is pending because it might take longer in some places than others. Start chemotherapy, and depending on the receptor status, when it comes back, you can sort of manipulate your regimen depending on what the receptor status is. So if it's a hormone positive cancer, you can start with chemotherapy, do your emergent stabilization, and then use endocrine therapy or incorporate endocrine therapy while you're giving that chemotherapy. If it's a HER2 positive breast cancer, if those HER2 drug regimens are available, or if you can request them from someone, they're very, very important. They prolong survival significantly in patients with HER2 positive breast cancer. You can, again, start with chemotherapy, but try to incorporate that anti-HER2 therapy. If you can't get the pertuzumab in addition to the trastuzumab, just focus on getting the trastuzumab. So whatever is available, anything is better than nothing. In the triple negative breast cancer population, chemotherapy remains the mainstay of treatment. Those other new drugs might be more difficult to get in other places, but it's good to know that they are available in case you were able to get hold of them. I hope that answers your question a little bit.
Can I ask the last question? Okay, so I want to ask now, you were talking about aromatase inhibitor in the postmenopausal patients. So here it is, I think it's 20,000 per month. How much about $35. It is really challenging because those women, postmenopausal breast cancer, these women, they have done all their investigation and now they have to take it every month. They can take for 6 months and then it will be impossible. And also, it is not usually available. Sometimes it's difficult. We have to send the money elsewhere, not in our account, because people don't use it frequently.
What is that? That's not available?
Sorry? Aromatase inhibitor. like letrozole, yeah. So, you know, sometimes we have very few patients who are taking those drugs. So I want to ask you, is it possible if the family is not able to afford to give a tamoxifen in those post-menopausal patients?
Absolutely, absolutely. Aromatase inhibitors do have a better survival benefit compared to tamoxifen, but that doesn't mean that tamoxifen doesn't have any effects. Definitely, definitely giving tamoxifen if aromatase inhibitors is not available is definitely beneficial.
Okay, thank you.
Thank you. Thanks so much. All right, Dr. Abdal, we really appreciate you doing this for us, and thank you so much for our audience for joining, and thank you for our internal medicine residency program, you know, at Mingo Baptist Hospital, and you can see how passionate the residents are, and even during COVID-19, they are here to listen to the lecture. So thanks for joining us. All right, and Dr. Abdal, if you would like to do a you know, a stage 2 of the talk, or, you know, I'm happy to discuss that. And really excellent talk, and really excellent and informative talk. Thank you so much. Take care.
Thank you everyone for being here.
Thank you. Bye-bye.